We're going to get started in just a few moments. Welcome, everyone. Thanks for being a part of today's session. We're going to get started in just a moment. Well, hi, all. Thanks for joining us. I'm Michael Morella, Managing Editor at US News and World Report. Today's webinar focuses on how children's hospitals can plan for the future of pediatric care and COVID-19. We hope to explore the physical effects of COVID, as well as its impacts on mental and behavioral health, health disparities, delayed care, and much more. Now, before we get started, just a couple of quick notes. You can find full bios about today's speakers, along with details about past and upcoming webinars from US News Live at usnews.com/events. We are recording video of today's program, and we'll be making that available to viewers once the webinar concludes. And later on in the hour, audience members who have questions, we ask that you please type them into the Q&A feature in Zoom. Our moderator will try to give voice to some of those as we have the time. Now, to help us set the scene ahead of our panel, I'd like to introduce Dr. Mark Klein, Senior Vice President, Chief Medical Officer, and Physician-in-Chief at Children's Hospital, New Orleans. Welcome, Dr. Klein. Thanks for your time today.
Thanks, Michael. I'm happy to be here.
So this week, the CDC released an estimate that 3 in 4 kids have had coronavirus infections. Can you help us set the scene a little bit about where things stand in terms of children's health and this current phase of the pandemic? You know, what does the situation look like in New Orleans and nationally?
Yeah, I think we're at an inflection point in this pandemic. Of course, in the early days, there was this myth out that kids weren't infected at all, or maybe if they were, they had very mild illness. We learned that that was untrue, and that COVID could have pretty serious or even devastating impacts on children, as it has for adults. Over the course of the pandemic, we've seen about 13 million children who have been diagnosed with COVID. About 7 million in the last 6 months alone, about 120,000 children hospitalized, almost 9,000 with MIS-C, the severe multisystem inflammatory condition that can damage the heart and other vital organs. And as of yesterday, more than 1,500 children have died of COVID, according to the CDC, 476 of those under the age of 5. So the impacts have been pretty substantial. And then, as you mentioned, this new data from CDC would indicate that about 3/4 of children have actually had COVID infection through the end of February. So I think we're probably entering a phase where we're going to see fewer of these really steep surges, the sort of the pronounced events that sort of shut down society, where it's going to be a more smoldering type of infection. Dr. Fauci said yesterday we're entering an endemic phase. He clarified those remarks this morning. So, really these are just educated guesses. The only thing that's been predictable about this virus to date really has been its unpredictability. So I think none of us can say for sure. But it does seem, with the number of people out there now who have either been vaccinated or who have had infection and have some degree of immunity, we're in a much better place than we were. And of course, we have therapeutics now that we didn't have in the past. Specifically regarding children in New Orleans and nationally, our numbers are very low in New Orleans right now. We've been hit hard over the course of the Delta surge and the Omicron surge, but we don't have a single child hospitalized at Children's Hospital New Orleans today with COVID, and our test positivity rates are under 1%. So we feel very fortunate. We've caught a bit of a break. We don't know that it will last, but for the time being, at least we're feeling pretty good. On the other hand, nationally, the American Academy of Pediatrics says that case numbers are up by about 43% in children over the past 2 weeks. So nationally, there is a bit of a surge that's being seen in a number of areas across the country. So, that's kind of the story with acute COVID, and it remains to be seen what happens with acute infections over the months and even the years ahead. But when I say we're at an inflection point, what I really mean is that we may be transitioning away from a pure focus on acute infections and really more to some of the longer term consequences and manifestations of this disease.
Yeah, well, I know it's impossible to be predictive, but reflecting on these last 2 years and a couple of the things you just said, can you pinpoint, 2 or 3 major areas or trends that you think will prove transformative for the future of pediatric care in general? Even long after the pandemic recedes or as it enters, its next phases.
Yeah. Well, some of these I think will be discussed during the panel session, and so I don't want to preempt that. But I think on the positive side, necessity is the mother of invention. And I think some of the things that we've learned, particularly pertaining to novel ways of delivering care, telehealth being one example, some of what we've learned over the course of the pandemic, I think will be with us for the foreseeable future and will be an asset in other areas of healthcare to a degree that it hasn't been up until now. On the other hand, I think the pandemic has shown a bright light once again on the health effects of disparate access to services by race, or if you will, because of racism. The impact of this pandemic has been disparate. Whites in America have lost about a year of life expectancy, and that's huge. We've never seen that magnitude loss in life expectancy other than in the case of a world war previously. But then if you compare that to Blacks who've lost more than 3 years of life expectancy and Hispanics who've lost nearly 4 years of life expectancy, that's a stark reminder of what disparate access translates to in the case of this pandemic and of healthcare in general. So that's something we absolutely must address in a real and definitive way in the years ahead. We've talked about it for a long time, but COVID has really shined a bright light on it. I think another issue is disparate access to vaccines and therapeutics for children. Likewise, this is something we've been talking about for decades. It was really brought to light in the course of the HIV/AIDS pandemic, where adults gained access to highly active antiretroviral therapy, and moms and dads were being saved by therapy at a time when children were still dying without any access to the drugs that had saved their parents. And there were a number of FDA regulations that were put in place at that point, and legislation, the Best Pharmaceuticals for Children Act in 2002, and the Pediatric Research Equity Act in 2003, kind of a carrot and stick approach to encouraging pharmaceutical companies to study drugs and to gain approval for them in children. And so here we go with this latest pandemic. And one would have thought that children would be right there with adults in gaining access to vaccines and therapeutics, and it simply hasn't been the case. We still have nearly 20 million children under the age of 5 who do not have a vaccine available to protect them against COVID. And the main therapeutics that are being used in adults, Paxlovid, for example, the oral therapeutic that can keep disease from progressing and leading to serious illness or even death in adults, is not available for children under the age of 12. And so we've got to do a better job at studying these things and making sure that children gain access to medications and to vaccines contemporaneously with their parents. And then another thing that is on the immediate horizon is, what are the long-term effects of COVID? We know very little. We haven't had this virus for long enough really to fully understand what some of the manifestations of this virus might be over the long term. I worry a lot about the neurologic manifestations in children, the effects of the virus on the growing brain. We know very little at this point about that. Potential long-term cardiac and renal manifestations. There are these reports that many of you probably have heard over the past couple of weeks of these fulminant cases of hepatitis in children, maybe attributed to an adenovirus, but we don't know. Does that have a relationship to COVID? That remains to be defined. Type 1 diabetes may be as much as 3 times as prevalent after a case of COVID in children and adolescents up to the age of 18 years. We need to know a lot more about that. And then the last thing I'll say is that we need to restore faith in public health and vaccines. The bond of trust between health professionals, hospitals, and the public has been broken by misinformation and miscommunication. And we've got to find a way to reestablish that going forward. People have to have faith in public health. It has to be depoliticized. And where vaccines are concerned, we're already seeing degradation in rates of vaccination against usual childhood illnesses like measles, mumps, rubella, diphtheria, and so on. We've got to reverse that. We've got to restore trust in vaccines, which were the biggest public health advance of the 20th century. And there's no backtracking on that. We've got to restore trust in vaccines.
You've helped set up our discussion to follow very nicely. I just want to ask one very quick question too. Another big issue related to COVID-19 is the attrition of health professionals, which is certainly not unique for children's hospitals. Are you seeing this, or do you have a quick sense of what could be done to address that?
I think this is a struggle across the country. Yes, we're seeing it locally, particularly among nurses, but among other health professionals as well. And people are leaving the profession. They're moving on to other things entirely. COVID has put additional strain on an already very stressed system. And I think as we develop new novel strategies for delivering care, we're going to have to take into account that we're going to have to do that with fewer professionals than we have in the past. And so we're working hard, like every other hospital is, to retain our nurses and to incentivize them to stay, to recruit new nurses. But this is going to be an ongoing struggle for the foreseeable future.
Well, I want to thank you, Dr. Klein, for those insights and again, for setting up our discussion quite nicely.
Thank you, Michael.
Now I want to welcome our panel so we can dive into even greater depth about some of those topics we just covered. I'm very pleased to welcome the following individuals who are with us today. They are Dr. Gigi Chawla, Chief of General Pediatrics at Children's Minnesota, Dr. Julie Kaplow, Executive Director of the Trauma and Grief Centers at the Children's Hospital New Orleans and the Hackett Center for Mental Health in Houston, Dr. Dennis Lund, Chief Medical Officer at Stanford Children's Health, and Dr. Daniel Rausch, Chief of Pediatric Hospital Medicine at Tufts Children's Hospital and Chair of the American Academy of Pediatrics Committee on Hospital Care. Welcome to you all, and leading the discussion, I'll turn it over to Morgan Felchner, Executive Editor of News and Events at US News and World Report.
Thank you, Michael, and thank you, Dr. Klein, for setting the stage for us. We have a lot to cover today, so I'll just dive right in. Let's start with the good news. Just today, Moderna submitted FDA approval for its vaccine for kids under age 6. Do we think this is going to go through this time? We saw the same thing with Pfizer, but it didn't. Do you have a prediction around vaccinations in young children? And anyone can feel free to take this.
Well, I'll take a stab. The FDA has been pretty clear about the data that they were looking for to make approval for the vaccination under the age of 6. I haven't seen the Moderna submission, but I'm hopeful that they've been attentive to what the FDA has asked for. So they'll be able to get it through. I think the challenge isn't so much getting a vaccine approved, it's getting the public to take it. We've had a vaccine approved for children over the age of 5, and yet we've had very poor penetration into the overall population of children age 5 to 12. in getting the vaccine. So there are certainly people who are eager for this and have been waiting for it, and I hope it's approved for them. But more importantly, to Dr. Klein's point, we need to restore the public trust in both the approval process, the safety of vaccines, and getting it to our population, both the people who want it and are having difficulty with access, and for the people who have hesitation about it.
Do you have any thoughts about what we might need to do to restore that trust, and how we can get more people to get their children vaccinated? Dr. Lund, any ideas?
Well, I think that, what we are trying very hard to do is meet people where they are. For example, in Northern California, we have a very large Hispanic population. And the Hispanic population has been very tentative about vaccinations in general. But we also have a very large number of Hispanic providers, Latinx providers, who can, again, meet people where they are, communicate to them with shared backgrounds and shared experiences, and hopefully build trust that way. We try very hard, for example, through our federally qualified health centers to educate families that way, and literally go out and try to reach out to these families where they are. It's a process though, because they're inundated with sources of mistrust on the web and on social media, and it can take a lot of work to overcome that.
We'll get back to more health equity discussions later, but for now, Dr. Chella, can you give some thought as to what comes next with COVID and what can we expect? We saw Dr. Anthony Fauci saying that we're reaching a new endemic level. What does that mean, and how will the virus evolve over time?
Well, I think it'll take us some time just to understand how the virus will evolve over time. We're really in a mode of just being highly reactive at this point. And as we begin to pivot to what something could look like in a more endemic format, at least I think for now, what we are really trying to incorporate is having those discussions and answering questions with every encounter that we have, and really trying to spread science throughout every opportunity with patients and families, and be available to answer their questions so that we can help kind of guide the next steps in how we all as communities recover.
Well, we started with the good news of the vaccine hopefully being available soon. I want to turn a little bit to some of the scarier stuff. So, parents of children have heard a lot about multisymptom inflammatory syndrome in children, and the concern around that and the confusion around that. What have you seen at your hospitals with MISC, and how concerned should parents be about this?
Well, we've seen a very small number of cases at Packard. We actually reported the very first case of MISC. We didn't know that it was actually COVID associated when the case was reported, because actually at that point we didn't have good testing for COVID. But the number's been small, but the consequences are very, very, very serious. And I think that there are also some concerns about side effects from vaccines. So, for example, young male athletes are quite concerned about getting cardiomyopathy or myocarditis from a vaccine, and it has actually prevented a number of them from getting vaccinated. We don't understand these things, and on the scale of risk, they're pretty rare events, but they are quite scary events. And I think we just have to keep reassuring families that the likelihood is very, very low.
I've had the opportunity to take care of a fair number of children with this. And as Dr. Lund said, some of these children can get quite sick, need intensive care, unit stay, and interventions. On the plus side, they do well when they're taken care of. So the number of deaths attributed to MIS-C have been exceedingly low. The risk for MIS-C is still larger than the risk associated with the vaccine, even in the at-risk age group, the young adult or older teen boys of getting cardiac side effects. What it has pointed out is emerging understanding of the illness. It's also been a capacity issue in terms of our emergency rooms and the number of tests that are generated by this and how to interpret tests that we didn't get before. So there's a number of tests that are associated with making this diagnosis, but we don't know what the background rate of some of these test positivities are because we didn't test every 12-year-old who came in with a fever and some of these other symptoms. So some of this is learning as we go along. And then it's an access to care issue. So we talk about this on the airwaves, and some people with the ability to get to an emergency room or a testing center are getting picked up perhaps at a milder version of this. And other children who don't have access to emergency rooms that deal with pediatrics or just can't get to hospitals aren't able to do that until they're much farther along in their illness.
One other scary thing that we've heard a lot about is long COVID. Is there anything definitive to share yet about how long COVID is affecting children? Dr. Lund, have you seen anything in your hospital?
No, I don't. I don't think there's really anything definitive. We do know that the children who have long COVID need multidisciplinary support, and the question is going to be how to best provide that, because the number of long COVID cases that any individual children's hospital is likely to see is not going to be very large. So hopefully we can learn a little bit of something about how to take care of these patients from our adult colleagues who are likely to see a lot more long COVID than we will in the pediatric population. So, but I'd be interested in what Julian and Gigi have to say about that.
Yeah, I agree with Dr. Lund. I think there is a significant burden of mental health and maybe more of the brain fog associated with it, that it is difficult to sort out between just the overwhelming mental health aspects that we're seeing right now. So I think time will tell a little bit more what are part of the physical aspects of long COVID and the mental health aspects of long COVID and how that plays out.
And I'll just add to that, Gigi, that, we've been using the term psychological long COVID to really describe what so many children are experiencing in terms of the mental health effects, the long-term mental health effects of COVID, particularly those that are most likely to experience those long-term effects, which are children who've experienced losses and traumas during the pandemic. And so, of course, we are seeing very high levels of distress, including depression, anxiety, but also post-traumatic stress and maladaptive grief reactions. And even though there's been a lot of attention focusing, thankfully, on long COVID in general, I think one of the areas that we really need to be paying close attention to is that psychological long COVID, as we're going to be seeing a lot of that for years to come.
I think it's going to be very hard to parse this, because if in fact 60% of children or more have been infected with COVID, and many of them have suffered losses, but not only that, but they've also missed a year of school. And we know that school is not just about education, it's also about social psychological development. It's going to be really hard to kind of parse out what's due to COVID and what's due to all of the social and psychological disruption that's been associated with the pandemic.
I think it's a good time for us to pivot about some of the other effects of COVID. Mental health, like everybody's been talking about, it is one of the key things. And the picture is very bleak for a lot of kids. Even before the pandemic, the demand for mental health services was rising. What have you seen at your own organizations, and how are you working to address the needs and ensure that care is equitable? Dr. Kaplow, would you like to start?
Sure. So, as I'm sure many other hospitals across the country are seeing, and outpatient facilities, we're seeing very high levels of distress, as I said before. But often that distress is coming from youth who've experienced losses during COVID. And it wasn't necessarily a COVID-related death, although I can talk about that and the specific risk factors around that. But we're also seeing that when children have experienced losses during COVID, they have not received the necessary social support that they're accustomed to receiving after a death. They have often, as with adults, not had the opportunity to say goodbye to that person. And sadly, we're also seeing a lot of guilt and shame around those children who somehow feel as though they may have transmitted the virus to their loved one who ultimately died. And in fact, just the other day, we were assessing a young child who said, "I killed my mommy." She was 9 years old and believed that she had brought home the virus to her mother, who later died. So I think there are all kinds of additional risk factors in the context of the pandemic that are making that level of distress even more intense. And so really paying close attention to how do we address the traumas, the losses, and those grief reactions that are often going overlooked.
And maybe from our other panelists, can you talk about how some of your children's hospitals are approaching mental and behavioral health care now?
Yeah, I could sure go next. I think we've really leaned into ensuring all aspects of the continuum, and that is really all the way from in our preventative care settings and primary care, trying to integrate behavioral health specialists there, really all the way through to launching our first partial hospitalization program, and later this year an inpatient psychiatry, a psychiatry ward. And that's really because we have noticed up to a 30% increase in patients seeking the emergency room for mental health support after suicide ideation. Just the degree of volume of patients that we are all trying to serve really has asked us to examine each part of our continuum and what we can do to enhance the care that we offer, doing it virtually, doing it in every aspect that we can to serve patients well.
It's been a struggle nationally for hospitals on what to do with these children who are hospitalized. And the impact is it's very difficult to deliver care when you don't have the resources, and they just get marooned in inpatient settings because they're at least physically safe there if you can't arrange for outpatient care for them. The other thing that's happened is it's displaced other care. So our freestanding children's hospitals, which do the quaternary care and the really high-tech care, can't bring kids in who need that care if their beds are full of kids who have behavioral health issues that don't require acute medical care, but they can't be safely discharged to other venues. So both us and our hospitals in Boston have struggled with canceling elective surgeries, and elective surgery is a relative issue. So if, getting a nose job is truly an elective surgery. Getting part of your cancer care, it's not an emergency surgery, but it's a surgery that can be scheduled. Getting that delayed or displaced has real impact on that child.
I mean, the scope of the problem is actually overwhelming. Prior to COVID, it was estimated that 1 in 5 children needed some kind of healthcare intervention for a mental health problem. And at that time, we did not have good funding mechanisms to take care of the mental health needs of our pediatric population. COVID has just accelerated that incidence of need, and we have not done anything to actively increase the amount of funding available to try and take care of the pediatric population with mental health needs that's exacerbated by COVID.
And you mentioned the cost and things like that. So, there's lots of tales of very long wait lists to see a therapist, insurance companies not covering therapy, all that sort of stuff. Do you see a way forward here? What can we do? What can hospitals do to sort of make the situation better?
Well, I think we have to advocate. This is where it's really important for advocacy, and we actually, our own local representative in Congress has been the chair of an important committee, and we are trying to get her to sponsor a bipartisan bill to put more money into mental health funding for children. I think we have to do that. Also, mechanisms of mental health payment it'll differ from state to state to state. For example, in Northern California, the mental health portion of the Medi-Cal, which is our Medicaid budget, is held by the state healthcare, the county healthcare system. So in fact, even though 42% of the children that we treat at Packard are on Medi-Cal, we actually do not have a contract with Medi-Cal for mental health services. So all of the mental health services that we have to provide for children at Packard, we provide with no reimbursement whatsoever. And it makes it very, very hard then for children who, are not coming to us because they're hospitalized, but they need to have like day hospital programs and things like that to find ways to fund those needs. I don't know how other states are handling it.
I'll just chime in. I think that obviously access to care is a huge issue. And what we're talking about and what Dennis just said is so true, that we need to be advocating for better access. One of the ways that we've been doing that is, advocating for more collaborative care models where psychologists, social workers, mental health providers are embedded where children are. And that may be in the hospital, that may be in the pediatrician's office, that's also in the schools. And ensuring that kids are getting screened and assessed and treated where they're most likely to receive those services is one of the, I think, more important things that we can and should be advocating for.
You're touching on one of the other things that I wanted to address, and that's some missed and delayed care. With schools closed, children were not being seen by all these adults that are mandatory reporters for abuse and things, but also just school counselors catching something that's going on. Are there things that were missed during COVID, either preventive care, screenings, regular vaccinations that might have ripple effects? Dr. Chawla, would you like to start?
Yes, I would love to start. So definitely, I would say, the balance that we had to face in our organization of serving the acute needs for patients, their acute health needs, their acute mental health needs, did come at a cost of being able to also offer as robust services for preventative health needs. And some of those preventative health needs, those well child checks that sometimes people take for granted, those are your entry point for understanding where kids and families are at, making sure that they get vaccinated, making sure that they get hooked. It's your front door to getting hooked up to services, community services, developmental services, and also access to the specialists that an organization has as well for much needed specialty care. And all of those things also the ripple effect of not getting access to your specialist for your chronic health care, not hearing from your trusted provider on how important your measles, mumps, and rubella vaccine is, and the ripple effect and delays from that lead our whole community to being at risk, and the ripple effects from that.
It could possibly lead to an entirely new patient population that children's hospitals haven't really served until now. How do institutions build programs to prepare for kids moving forward, and what changes do they need to make?
Well, I think it's really through pausing to recognize where you've been, what your data tells you, where the disparities are, and then partnering with others in the community to try to close those gaps. And whether it's with your health department or with schools, like Julie had mentioned, really bringing care to where kids are and where the care is needed, rather than expecting everyone to always come back to the way things used to be, which we can't go back to the way things used to be. We created barriers to care there, and the outcomes that we have, where we had disparities in immunizations, we had disparities in well child checks before the pandemic, now are exacerbated. So we have to find different methods and different ways to close those gaps.
This is a good opportunity for us to talk about some of the strategic partnerships and community collaboration that needs to happen in order to care for all these children. So strategic partnerships between children's hospitals, private entities, they're all really important to making sure that kids get cared for. What can and should children's hospitals do to reimagine how they operate and partner across sectors to meet the needs of kids outside the hospital? Dr. Lund, would you like to start?
Sure, thanks. Well, it's a great question. I have a quote that I like to say, and that the good news about Northern California is that there are 2 million children that live in Northern California. The bad news about Northern California is they don't live in Palo Alto, and we have long known that we have to go to where people are. Given the traffic and geographic constraints of the Bay Area, it could take a family 3 hours to come to Palo Alto for an appointment. So we've created a distributed model of care. We have 65 clinics in 65 different locations throughout the Bay Area, all the way down from Monterey Peninsula up into the East Bay and north, and we've created both a faculty practice model and a foundation model with community physicians who work for Stanford Children's Health. But then also what we do is we partner with a number of community hospitals, and we started with that around NICU relationships over 20 years ago, but we've broadened that out now to having community relationships at high quality community hospitals where we can provide PICU, NICU, intensive care services, as well as specialty services. And then, as I said, big outreach to the FQHCs and ability to go to those populations. And then we are very, very intentional about trying to target what we refer to as pockets of poverty around us. And you don't think about a lot of poverty in Silicon Valley, but there is a lot of poverty in various areas in Silicon Valley, and we try to go to those areas and target them with our teen van, because those patients can't come to us. We've got to go to them. So we basically partner with everybody, and that's kind of been our approach.
Dr. Kaplow, could you talk a little bit more about collaboration with schools?
Sure. So the Children's Hospital New Orleans has a program called Thrive Kids, where we have partnered with Jefferson Parish, which is the largest school district in Louisiana, to be able to actually bring our physicians, our therapists to the schools. So in that way, they, again, addressing the issue of access to care, ensuring that kids are getting the treatment that they need. One of the things that I think has definitely been eye-opening for the schools is recognizing the number of kids who are experiencing mental health issues, the number of kids who are presenting with trauma and grief. And so because of that, we are also partnering with them to incorporate better risk screening and assessment using evidence-based tools to be able to identify those kids that have experienced losses or traumas during the pandemic. And then we're also training all of their school-based clinicians in one of the evidence-based practices that we ourselves use, again, in order to empower the schools to be able to better address the mental health needs of the students that they serve. And, as Dennis just mentioned, we're seeing in our under-resourced areas sort of that accumulation of traumas and losses. So we want to ensure that we're addressing, again, not just the COVID-related deaths that many of them have experienced, but all of the other issues that they've been experiencing for so long that have actually been highlighted because of COVID. So issues of racial discrimination, community violence, certainly deaths due to homicide is something we're seeing a lot of. So with the partnership through the Thrive Kids program, we're better able to address all of those, both mental, behavioral, and physiological and physical needs that they have.
I think one of the things that we've tried also is really looking at our patients across the social vulnerability index and trying to match out schools in those areas, partner with schools in those areas, and bring our mobile clinic to those sites to help kids get the care that they need, their vaccines that they need. And in addition, some of the other ways that we've tried to innovate and bring care to the community has really been in our DriveUp model. So we've tried DriveUp Vaccines, and this is no easy feat in Minnesota in the middle of the winter, but DriveUp Vaccines for not just COVID, but for all childhood vaccines, as well as DriveUp Care. And that for acute illness type care, that has really been, I think, a way that families who are especially scared or worried about coming into clinics can start to seek care that way as well.
This is a nice time for us to transition to talk a little bit more about health equity. How can pediatric hospitals and other health providers play a role in addressing children's health equity and the social determinants of health? Dr. Rausch, would you like to start?
Sure. It's worth pointing out that only 25% of pediatric inpatient care takes place in freestanding children's hospitals, and 50% takes place in hospitals within hospitals. So a fair amount of pediatric care takes place in our community hospitals and remote access hospitals. And there was a trend prior to the pandemic of losing that bed capacity so that children had to travel farther to get seen in emergency rooms and places that accepted pediatrics, and then would be transferred to more specialized facilities. So COVID has exacerbated that. Facilities that maintained small pediatric inpatient units transferred that care to the local or distant freestanding children's hospital because they needed the adult bed capacity, and they have not reopened their pediatric beds. So we're seeing that it's difficult for some children to actually get care that they need close to where they live. And it's something that we need to pay attention to. There's risk to transferring children long distances. There's the risk of the transfer itself. There's the displacement of the family. There's the impact on lost income for families that need to travel long distances. And then it displaces children, again, who need those quaternary care centers. So asthma, diarrhea, dehydration, those type of things should be able to be cared for relatively close to where the child lives. And if we're having inequity in where that access is, so if it's affecting our underserved areas more than our higher income areas, then we're going to see worse health outcomes associated with that. So it's something we need to pay attention to and monitor. Unfortunately, there is no national organization that looks at bed capacity and bed utilization in pediatrics in the United States. So a lot of this is regulated by local ordinance. Even states don't monitor, not even all states don't monitor this. So it is a policy and advocacy issue.
Can anyone point to some specific examples of solution-oriented insights that you can share about efforts that work to address things like homelessness, food insecurity, mental health challenges, education, inadequate access to care, all the different social determinants of health that really impact how children are receiving their care?
So one of the things you have to do is ask. You have to find out if there's a problem. One of my colleagues here has done some work on utilizing hospitalizations to do screening for that. And I'm sure in primary care practices, instituting screening so that you can identify the kids and families who are struggling and then hook them up to resources.
Yeah, I completely agree with Dr. Rausch. That's exactly what clinics are doing, is they're doing all of that screening, hopefully at every encounter, looking for not just food insecurity, but also transportation needs and legal needs. And our organization has developed a health legal partnership for our patients and families to really work with their landlords or potentially work with immigration issues or whatever those needs may unfold that impact or create barriers to achieving a healthy experience.
You know, we just did a national experiment on this where, as part of COVID relief, we gave families with children a stipend, a monthly stipend for the family, for their children. And the data would suggest that these families spent this money on food and on clothing and on shelter and on their basic needs. Now, through our inimitable wisdom, we are letting this support expire, which is I find it to be very sad. But this is the kind of thing that is relatively simple, can be done at fairly little cost in the grand scheme of things, and has a huge impact on our pediatric population. When you think that, you know, over 40% of the kids in the United States live at or below the federal poverty level.
Yeah, I'd go further and amend that the cost is not minimal. The cost actually is a huge return on investment. And study after study has shown that if you invest in children and make sure that they're well, that they're fed, that they're educated, they become productive citizens later on in life. And so the cost to not doing this is substantial. Poor health, poorly educated adults, people who become involved in other activities to support themselves or to separate themselves from the bad reality that they're stuck in. So this makes economic sense. It's not just good health care, it's good fiscal care.
One thing that we kind of keep going back to is no matter how many changes we make and how much healthcare is available, if the trust isn't there, there's not much we can do. So one of the most important things some studies have shown is that there are doctors and nurses that look like the patients. So I wonder if you can talk to some of the things that your hospitals are doing to increase diversity and foster more inclusive environments within your own walls to help build trust with some of the patients.
I think that's such an important issue, Morgan, especially when it comes to mental health issues. And what we've really been trying to focus heavily on is exactly what you said, trying to ensure that the individuals who are working with these kids actually reflect the population that we're serving in terms of diversity. And I would say that comes up very frequently, especially when we're dealing with kids who have experienced, again, racial discrimination, racial traumas, where having to disclose that information to someone who looks like them actually is much more effective and works much better than if it's someone who they don't feel like can even relate on any level to what they have experienced. So I think paying close attention to that, but then also, really focusing in on our own implicit biases. We're doing some trainings around, paying close attention to what we can do to ensure that we're reflecting carefully on what our own biases might be doing in terms of that therapeutic rapport, and even with others throughout the hospital who are interfacing with very diverse populations. So I think a lot of the work comes from the top down at the organizational level and paying really close attention to those particular issues.
I'd say a lot of national organizations are starting to look at this on how to prime the pump and where do you make the impact in people who are looking to go into this field. And that's at the middle school level. You have to get students interested in science and want to pursue this as a career. By the time they get into college, you've already seen a whittling down of people who can take the next steps along the path. And by the time you're looking at admission into medical school or PA school, you're looking at substantial financial hurdles where if you're an underrepresented minority or you're in the lower socioeconomic groups, it just isn't possible to take those next steps. We finance medical education completely differently in the United States from almost every other place in the world. And so we put these substantial barriers to change the makeup of our workforce. They're structural and they're ingrained, and we need to look at how we provide access to training and the people who are interested in that training. And that goes again down to high school and middle school.
Yeah, I think, organizations need to show their commitment to diversity, equity, and inclusion. For the past 2 days, actually, I've been interviewing candidates for a chief diversity and equity DEI officer for Stanford Medicine. Since the George Floyd event, we've been very, very intentional about trying to educate all of our people around, implicit bias training and things like that. But large organizations, hospitals, universities, we need to put our money where our mouth is and build programs. I know, Daniel mentioned the pipeline program. Tufts has been very, very good on the pipeline and trying to get underrepresented minorities into the STEM program. I'm aware of their programs. But the other piece of it is what we do well at Stanford is we have a very diverse student population. We have a very diverse set of residents, but then they drop off further on because they don't have a lot of people that look like them that are faculty or department chairs. And so, there's a lot of work to be done there to diversify the leadership in the medical organizations as well.
And I would say in Minnesota, Children's Minnesota is positioned about 1 mile away from where George Floyd was murdered. And it has been just a significant commitment that Children's has made to really prioritizing diversity, equity, and inclusion, all the way from the executive level to the front line. And we're committed to doing we focus on implicit bias training, like Julie had mentioned, trauma-informed care, but it has really become part of the hallmark of who we are. From hiring to care delivery. And it just, I think I can't speak to this more strongly, that in order to really serve patients well, we do have to look like our patients.
Let's shift to the future and what things have really emerged because of COVID. So what innovations have emerged during or maybe even because of COVID that are now standard? We saw telehealth take off, but what else is going on? What else should we be looking for in care?
Well, I would just jump in, Morgan, to do a little bit of a deeper dive with the teletherapy, because I do think that has been, I hate calling it a silver lining, but I think in some ways it has been a silver lining that we've recognized that teletherapy is just as effective as in person. And that actually what we've found is that we see less attrition when we enroll kids through teletherapy. So it's much easier to show up, to just get on Zoom or whatever the platform is and talk. And I also think that in some ways when kids are revealing issues around trauma or grief, sometimes having that computer screen there is actually a little bit protective for them. They feel more comfortable sometimes opening up in that way. So I think that's been an innovation that we have found to be successful and that we're continuing to pursue through Children's New Orleans, offering teletherapy throughout all of the different areas that we treat. And the other thing that I'll just mention in terms of health equity is that we recognize that many families don't have access to a laptop or a computer. We've been successful in using just the telephone to conduct therapy with kids. And I think sometimes people dismiss that as an option, but that's also been very effective for those that are not able to access, the tools they need to get onto teletherapy.
Yeah, I would second what Julie said. It's been interesting. One of the groups where it's worked extremely well for us has been psychotherapy for adolescent males. They seem to somehow be much more willing to open up to a computer screen than in person. We've been pretty fortunate that we ramped up to the point where we were doing half of our ambulatory visits by telehealth. We've been able to maintain about 20 or 25%. And part of that speaks, I think, again, to how hard it is to get around in the Bay Area. It also speaks to the fact that California is a parity state. But I do think one of the cautions that we have is that there were a lot of allowances that were made to allow physicians to work across state lines. by telehealth as emergency measure for COVID, and that now those variances are being withdrawn, and we're going to go back to the difficulty of providing telehealth across state lines. And I'll give you one simple example. Adjacent state for us is Nevada. There is one pediatric rheumatologist in the state of Nevada. And so we provide a lot of the telehealth rheumatology service, pediatric rheumatology services to patients in rural Nevada. And so we have to, again, goes back to our advocacy position here, is that we have to be sure we don't backslide from some of the gains that we had, that we got from COVID, or especially around things like telehealth and remote care.
And I think we're just scratching the surface of what we can do remotely. As I was talking earlier about losing access in smaller facilities, I think we can reimagine access in those facilities and allow for specialists to deliver care remotely. I think we can start looking at hospital at home programs. When you think about the necessity of what it would take to treat someone at home, you need some caregivers who are there for you. Well, what's better than families and parents and adult caregivers to take care of a child? If they had the equipment and they had remote monitoring, we could probably avoid a significant number of the need for hospitalizations, not the care for the child, but the need to bring them into our four walls, as opposed to letting them be at home, where they'll be more comfortable and in many circumstances dealt with better by their family, rather than having to travel long distances and be left in the hospital by themselves.
Yeah, I would also mention that, I think we've tried in primary care to lift some of the attachables. So whether it's a stethoscope virtually, or ear, for an otoscope virtually, and that has just been really difficult for families to absorb at home. So a lot of the care has remained focused on specialty visits and on mental health visits, and primary care, other than dermatology type or mental health visits within primary care, have been difficult to lift without some of those exam pieces.
So we've talked a lot just now about the benefits of technology. I want to turn to a question from the audience, because technology has opened many doors for young people and families, from cutting edge advances in care to remote learning and connectivity during the pandemic. But it has also demonstrated profound negative effects on children, especially with regard to social media. I wonder if anyone has any insights, or how providers and even parents can successfully balance the good and the bad of new technology. Dr. Kaplan, maybe you want to take it?
Sure. This is a tricky one, which I can easily relate to, having two teenage boys. I think that what it really boils down to is open communication between parents and children. And I'm not saying that as a pat answer, but really being able to help, giving parents words to be able to use with kids about what it is they're seeing, what they're looking at, having some kind of monitoring going on, while obviously not infringing on their privacy or making them feel like they are being watched carefully, but really having that open communication about the dangers associated with social media, and having those talks about what is real, what is not real, and who should you be corresponding with and who should you not be. And I think it really does boil down to that open communication between parents and children about what they're viewing.
Thank you. And we're just about out of time, unfortunately, but I want to give everybody a chance to give any final thoughts, any last words of wisdom for all of our attendees. Dr. Lund, would you like to start?
Well, first of all, I want to thank you, Morgan, and Michael, and the U.S. News Group for bringing us together for this. I think was a great conversation. I am optimistic that we are heading in the right direction with COVID, and I think we've learned a lot of lessons, and I hope we've been taking a lot of notes. It could come back again this winter in another form, the next letter of the Greek alphabet, or however we want to name it. But I do think we've gained a lot, and there's a lot to study, and we need to continue to learn from it.
Thank you. Dr. Chawla?
Yeah, I think my parting thoughts and lessons that I've learned thus far is that we can't do it alone. As a children's health organization, it really is about partnering with your community and everyone doing their part. And so whether it's across school sectors or government sectors or other nonprofit sectors, other healthcare systems, we're kind of all in this together. We've got to do it together.
Dr. Rausch?
I, again, appreciate the opportunity. There was a recent article that looked at deaths that were prevented in California between better treatment and vaccination. And for everything that's gone on and all the missteps and miscommunication, the truth is we've done an incredibly remarkable job in healthcare to save lives. Could we have saved more? Absolutely. Could we have done a lot worse? Yes, we could have done a lot worse. So the system actually works fairly well. We've learned to communicate with each other. We've learned to break down barriers. We've learned where government can help facilitate this, and I think we're better positioned. The question is, will we invoke those lessons when the next event comes along?
And Dr. Kaplan?
Thank you. I think I will just end by saying that I think one of the lessons learned throughout the pandemic has been to be very cognizant of issues of vicarious trauma, vicarious grief, secondary traumatic stress among our providers. These are real issues that I think are heavily contributing to compassion fatigue and burnout. So at Children's New Orleans, we actually have a series where we're focusing heavily on addressing those issues throughout the entire hospital, whether it's our 51-bed psychiatric unit or other areas throughout the hospital where they're seeing and treating so many families and children who are suffering. And so that's, I think, a really important piece that we need to be paying close attention to going forward.
Thank you so much for coming and joining us. It's clear COVID-19 has really upended our healthcare system, but it's grown and changed, and hopefully there's a lot of lessons that all of our attendees can take out from this panel on how we take pediatric care from here. So thank you so much for being on the panel, and to the audience, thank you for joining us, and we hope you'll join us again another time.